Hello everyone, this is me Nasiha, Intervention Cardiology Fellow from Egypt. It's my pleasure to present this case in Cardiovascular Innovation Digital 2020, a dissection to stent or to leave. Our patient today is 58 years old male patient complaining from exertional epigastric pain which lasts for 2 weeks. He is hypertensive, dyslipidemic and ex-smoker. His clinical examination was unremarkable. ECG was normal. Echo showing grade 1 diastolic dysfunction. Stress ECG was positive. Coronary angiography shows significant proximal to mid LAD lesion which is followed by aneurysm. Here are multiple views. Regarding RCA, there is a borderline RCA lesion which is followed by distal dissection. So the decision was to do PCI to LAD first. LAD wiring by Asahi Soft. Then LAD stenting using Resolute Onyx 3 by 30 mm with good final result of LAD. What is the next step? What is the decision regarding the RCA lesion and the dissection? Leave it or wire and stent? Does the dissection of the RCA affect the flow? May it be the cause of the symptoms? Regarding this scheme, we decided to hospitalize the patient for 2 to 4 days. So, we terminate the procedure at that point and hospitalize the patient for 3 days and follow up of the chest pain and the clinical states. And the patient was encouraged for early mobilization, but unfortunately he was still complaining from the same criteria of chest pain with no ECG changes. The decision was to do coronary angiography and stent the RCA lesion and dissection. The LAD stent was patent and the RCA showing the borderline lesion which is followed by dissection. Wire the RCA by Asahi Soft. Multiple views to detect the lesion. Actually, there is no significant lesion after wiring the RCA and the dissection was sealed. The dissection was sealed by the wire with no need to put a stent due to non-significant stenosis after sealing the dissection. The patient had been transferred to CCU with no symptoms at all for 4 days. Multiple follow-up visits were done for 1 year with no chest pain. Our take-home message: spontaneous coronary artery dissection is an important cause of acute coronary syndrome, particularly in women even without cardiovascular risk factors. It's difficult to differentiate between symptomatic and asymptomatic spontaneous coronary artery dissection, especially in presence of significant lesion in another coronary artery rather than the dissecting one. Most coronary dissections will heal spontaneously, and conservative treatment is recommended for uncomplicated cases. Patients with left main involvement, complete vessel occlusion, ongoing chest pain, or hemodynamic instability will require coronary vascularization. PCI results are suboptimal in this challenging group of patients. PCI should be performed by experienced operator with the use of intravascular imaging and preferably with on-site surgical backup due to increase the risk of complications. Although long-term prognosis is excellent, the risk of recurrent spontaneous coronary artery dissection events is significant, with an average rate of 5% per year. Thank you and stay safe.